Welcome to all audience. I'm very happy to be here today with you to speak about the European Society of Cardiology new guidelines for management of atrial fibrillation 2020 on behalf of the Cardiology. I'm very happy to share this session with Professor Mohammed Orabi, the head of the Cardiology Department, Suze University, and our Professor of Cardiology, Professor Fatih Makladi, who is the founder of the department and one of the founders of Suze University Faculty of Medicine. Very happy to have
أحمد سامعني؟ بقول لك في حاجة في الصوت عندك، غالبا الميكروفون أو حاجة زي كده، ممكن يكون بيشتغل أو مروحة أو هواء، حاجة كده.
لحظة واحدة، ده صوت كيف مش لحظة. هل كده الصوت افضل يا فندم؟
تمام كده 100 100.
تمام. So sorry for this technical error. يعني متوقع بعض التكنيكال ايرورز يعني. بسم الله. I'll go ahead, but just I'd like to welcome Dr. Ahmed Tageldin, my electrophysiologist colleague, lecturer and consultant of cardiology and electrophysiology, Cairo University, and my colleague, Dr. Ahmed Salah, lecturer and consultant of electrophysiology, Suze Canal University. So let's go straight ahead to this guidelines. And I'll start first very quick with Gerhard Hendricks. Gerhard Hendricks is a German electrophysiologist, and he is one of the eminent electrophysiologists in the field of AF ablation and VT ablation as well. He has more than 350 publications in the field of electrophysiology, and he is the chairperson of these guidelines, and he is well-known a person of practicality. Usually he put things in together with a very clear way of organization. I have seen him many times in the ESC, in the EP, and he is a very well-known figure in electrophysiology. Atrial fibrillation is a very common disease, and you can imagine that the worldwide prevalence is about 1 to 2% worldwide. So if we count this in Egypt, so we might have about 1 million or more of AF in Egypt. This is a very large number, and if you look to the mortality and morbidity, it's very significant, either worldwide or even here in Egypt. In Europe, 1 in 3 have a lifetime risk of atrial fibrillation above the age of 55 years, and this is a very large number. So it equals about 35–36% chance of having atrial fibrillation. There are so many AF-related poor outcomes, starting with death, which there is a chance of about more than two-fold increase in mortality related to atrial fibrillation, especially because of heart failure and stroke. Also, there is a very significant prevalence of stroke, up to 30%. 10 of them % is cardiogenic stroke, and it might lead to cardioembolic and related to other comorbidities. LV dysfunction and heart failure are very common in AF, about 30% again. and simply this is because of excess ventricular rate or some valvular changes or irregular ventricular desynchrony. Cognitive impairment, vascular dementia is very common in patients with atrial fibrillation, especially age above 60 years old. Depression is very common because of poor quality of life in patients with atrial fibrillation, especially in females. AF is related with depression. Impairment of overall quality of life in more than 2/3 of patients is very common. And again, this is related to other disabilities, strokes, heart failure, and poor physical tolerance. Hospitalization, again, is very common and related to atrial fibrillation, about 10 to 40% annual hospitalization rate. And this is related to AF itself or AF comorbidities. So you can imagine all these comorbidities of atrial fibrillation, and this give you some sort of the real burden of atrial fibrillation. So what's new for this year is not the definition of clinical AF, which is symptomatic or asymptomatic AF that's documented on surface ECG. What's new somehow is subclinical AF. And subclinical AF refers to asymptomatic individuals whose intracardiac device, either pacemaker, ICD, or implantable loop recorders, could capture atrial high rate episodes. And this somehow a new definition for subclinical atrial fibrillation. The management of clinical AF is very clear. However, management of subclinical AF is not reaching a consensus degree of guidelines. So this is how we diagnose subclinical AF. Usually we capture it from patients with implantable loop recorders or intracardiac devices like ICD or pacemaker. If we can capture ECG on surface ECG, on Holter monitoring, so this is called clinical atrial fibrillation. What can we do with atrial high rate episodes or subclinical AF? If it is very uncommon, short runs, just observe. If it is very long ones, up to 1 hour and less than 24 hours, observe, and you can exclude secondary causes. If it is very long and more than 24 hours on capture, so there has to be some sort of medications, either correction of any underlying medications or giving the patient any heart rate lowering medications. Again, there is another assessment as regarding the thromboembolic risk. So we have to do Bled Score for those patients, and we will come to that in few minutes. Who should be screened? Actually, we should screen all patients above age of 60-year-old, hypertensive patients and patients with obstructive sleep apnea. Systematic ECG screening should be considered to detect AF in patients above age of 70 years old, even without any other risk factors. Benefits are so much. Prevention of stroke, systemic embolization, prevention of subsequent onset of symptoms, prevention or reversal of AF by electrical or mechanical atrial remodeling, prevention and reduction of AF-related morbidity, hospitalization, mortality, and reduction of the poor outcome of atrial fibrillation. So those are the important determinants of atrial fibrillation: aging, ethnicity, genetics, and male gender. And those are the non-correctable risk factors for atrial fibrillation. There are so many other risk factors, as you see here: physical inactivity, lipid profile, alcohol consumption, smoking, and they are all correctable, even obesity as well. There are some comorbid conditions which could induce or exacerbate occurrence of atrial fibrillation. How to screen? We have so many old and new diagnostics for AF detection. Watch, like the smart watches, the wearable devices, the stroke unit telemetry, the ambulatory blood pressure, or even home-based blood pressure, simply palpation, and there are some other patches, devices, implantable loop recorders, and some other mobile phones and smartphones which you could diagnose AF. So there is no excuse why didn't we, or why couldn't we diagnose or screen atrial fibrillation. This 4S concept is very new for these guidelines. This is a new concept of what's called atrial fibrillation structured characterization. 4S. S for stroke, S for symptoms, S for severity of AF burden, I mean the rate of atrial fibrillation, and S for substrate severity. Stroke risk, and this could be assessed by the underlying Chad-VASC score, which we'll come to that very soon. Symptom severity by EHRA score system. Severity of AF, and this could be done by whether it's permanent AF, persistent AF, burden of AF, and substrate severity, and this is either by the comorbidities or other clinical characteristics and imaging techniques. So first, all AF patients should have medical history. We should know the AF pattern, the Chad-VASC score, 12-lead ECG, some important laboratory functions like thyroid, kidney function, electrolytes, and full blood count, transthoracic echo. Then selected patients with AF, we should have ambulatory ECG, transesophageal, some important biomarkers, coronary CT in suspicion of ischemia, brain CT in suspicion of cryptogenic stroke or any forms of cognitive impairment, and lead gadolinium CMR in making some decisions as regarding the cause of left atrial dilatation or fibrosis. And then there is a structured follow-up, which in the form of revision of those 4S every now and then. This is the EHRA symptom scale. Those are important 6 parameters: palpitation, fatigue, dizziness, dyspnea, chest pain, and anxiety. So each patient with AF should be screened for these symptoms. And this is the score of symptoms, starting from none and ending by disabling and passing over severe, moderate, or mild symptoms. Here, this is imaging in atrial fibrillation. So there are imaging modalities which you could assess anatomy, structure, function, and left atrial appendage thrombus detection. Cardiac MRI can detect all those items: anatomy, structure, function, and left atrial assessment, while transthoracic and transesophageal echo could detect the anatomy, the function, and the left atrial thrombus. It couldn't detect presence or absence of fibrosis and so on. So EP mapping could detect the substrate and the function, of course. So not all patients with atrial fibrillation will need all these sophisticated investigations. However, at least transesophageal and transthoracic echocardiography, then in selected patients, other investigations could be there. Stroke risk assessment is done via Chad-VASC score. Antiplatelet therapy alone is not recommended for stroke prevention in AF, and this is class 3. Oral anticoagulation is recommended for stroke prevention in AF patients with Chad-VASC score more than 2 in men and more than 3 in women. And for selected men of 1 Chad-VASC score or women with 2 Chad-VASC score, we might initiate oral anticoagulation. This is what Chad-VASC stands for: congestive heart failure, hypertension, age above 75, diabetes, stroke, vascular disease, age above 65, and gender. And this is the calculation of the Chad-VASC score for your reference. This is how we approach patients for anticoagulation. So if we have a diagnosis of atrial fibrillation, all patients with prosthetic valves or moderate to severe mitral stenosis should have vitamin K dependent anticoagulants. If they haven't, we should identify who is at low risk, which means 0 for males, 1 for females, so no antithrombotic needed, and who will need, if it is 1 or more in males, 2 or more in females. we should consider novel oral anticoagulants if there is no contraindication for most of patients who are indicated for oral anticoagulation. I know that the cost might be a limiting factor. However, most of these medications are available now in the health insurance system. I'm speaking about the real practice in Egypt. It's important while we are counting the Bled score to assess the bleeding risk as well. So we are not disbalancing the bleeding and thrombotic risk, and we'll come to the Bled score in a few minutes. What about coronary artery disease and AF? In AF patients with acute coronary syndrome undergoing uncomplicated PCI, early cessation of aspirin and continuation of other dual therapy, including oral anticoagulant and B2Y12, preferably clopidogrel, up to 12 months is recommended. And this is actually the stated statements of the European Society of Cardiology. Triple therapy with aspirin, clopidogrel, and oral anticoagulant longer than 1 week could be considered if the risk of stent thrombosis outweighs the risk of bleeding. And this is the hierarchy or how to go in patients with acute coronary syndrome or chronic coronary syndromes. And it's important, as I said, that we shouldn't go with the three antiplatelets and anticoagulant, which is the triple therapy for more than 1 week, unless there is a very high risk of stent thrombosis and we shouldn't go beyond 1 month because the risk of bleeding is very high. However, we can continue with B2Y12 inhibitors plus NOACs or oral anticoagulants as indicated. These are the guidelines, and you can see that for class 1 indication, if patients eligible for NOACs, it's recommended to use NOAC in preference to VKA in combination with antiplatelet therapy. And for patients with AF and acute coronary syndrome or AF with chronic coronary syndromes undergoing BCI, we have to go for 1 year with B2Y12 inhibitors, like preferably clopidogrel, plus oral anticoagulant, preferably NOACs, plus aspirin for only 1 week or less than 1 month according to the stent thrombosis chains. Post-procedural management of patients, we should look at the thrombotic risk factors, bleeding risk factors, and strategy to reduce bleeding associated with PCI. One of these important strategies is radial approach PPIs in patients with GI upset or Helicobacter pylori positive patients, and that's very important. Bleeding risk usually in hypertension, abnormal renal function, stroke, intracranial hemorrhage, bleeding history, labile INR, elderly patients, and concomitant medications like oral anticoagulants or non-steroidals or antiplatelets. Thrombotic risk factors, diabetes is the major one, then comes other prior acute coronary syndromes, recurrent multiple coronary artery disease, concomitant PED, previous stent thrombosis. Bleeding risk should be assessed via Bled Score, and that's very important score. Those are the modifiable and non-modifiable risk factors for bleeding. One of them is the age, the severe major bleeding, previous major bleeding before renal impairment, hepatic dysfunction, malignancy, genetic factors, previous stroke, diabetes, cognitive impairment. As you see, diabetes is a determinant of bleeding and determinant of thrombosis as well, especially in patients having PCI. So this is the Bled score. So uncomplicated hypertension, abnormal renal function, stroke, bleeding history, labile INR, elderly, drug or excessive alcohol drinking, and these are how to calculate the Bled. If we have a patient with active bleeding, it's important to assess the site of bleeding and compress it mechanically, assess hemodynamic status, and we should know the history of anticoagulation. If we have NOACs, we have to assess the severity of active bleeding. If it is minor, just delay NOACs for 1 dose or even 1 day. If it is severe or life-threatening, we have to consider a specific antidote like adenosate, for example, for rivaroxaban. If it is moderate to severe, so we have to assess symptoms to assess the further bleeding and endoscopy in some causes. If it is vitamin K dependent anticoagulants, if it is minor bleeding, again, we have to delay it. If it is severe, we have to consider prothrombin complex concentrates or fresh frozen plasma. In patients with intracranial hemorrhage, we have to wait for 2 to 4 weeks after intracranial hemorrhage. Sometimes we might need left atrial appendage occlusion if it is a reversible cause of intracranial bleeding. I'll try to bypass some points for sake of the time. Postoperative AF is common and is important. Long-term oral anticoagulation therapy to prevent thromboembolic events should be considered in patients with at risk for stroke with postoperative AF after non-cardiac surgery, considering the anticipated clinical benefit. However, beta blockers should not be used routinely to prevent postoperative atrial fibrillation, and this is class 3. So this is very important point. So for postoperative AF, if the patient is hemodynamically unstable, emergent cardioversion, if the patient is stable, we have to initiate anticoagulation, then to see whether to go for rhythm control or rate control. Lenient rate control, this is for AF in general. Heart rate less than 110 is reasonable and sufficient to improve AF-related symptoms. The primary indication for rhythm control is reduction of AF-related symptoms and quality of life. And this is, to me and for many electrophysiologists, is not an astonishing point, actually, because many patients with rate control are having good quality of life. Catheter ablation is well-established, safe, and superior alternative to antiarrhythmic medications to maintain sinus rhythm. So, outline of rate control strategy, background therapy in OLF patients, first choice therapy in patients with no or minor symptoms, therapy after failure of rhythm control, and therapy with risks restoring sinus rhythm outweigh benefits, because sometimes antiarrhythmic medications might cause harm to the patient, as you all know. So lenient control is reasonable, but in some patients, we have to go less than more tight control, which is less than 80 beats per minute, especially patients with heart failure, patients with CRTD, patients who have a very poor quality of life. And even we can go further for evinodal ablation and pacing in patients with tachycardiomyopathy who have failed repeated AF ablation. I'm not going to mention all those medications. However, you have list of medications which could be used to control AF. And for me, metoprolol succinate XL up to 400 milligram, which is a very large dose to control the rate in atrial fibrillation. However, you have calcium channel blockers, digoxin, amiodarone, and different varieties of beta blockers to use for rate control. This is the choice of drugs for rate control, and just not to spend so many time in this point, non-dihydropyridine calcium channel blockers is only indicated if you are sure that there is no heart failure, even heart failure with preserved ejection fraction. If you have heart failure with reduced ejection fraction or preserved ejection fraction, you can use initially beta blockers, then you can go for digoxin in some points, or even non-dihydropyridine calcium channel blockers if it is preserved ejection fraction. But if it is reduced ejection fraction, you have to go for amiodarone if beta blockers alone couldn't control the rate. What about the rhythm control? Rhythm control is indicated in patients with atrial fibrillation to improve symptoms and quality of life. So no mention for improvement of mortality except in patients with heart failure with reduced ejection fraction. We have what's called the upstream therapy, AC inhibitors or ARBs, mineralocorticoid receptor antagonists, statins, and baseline beta blockers, and all those medications have the pleiotropic effect to reduce the burden of atrial fibrillation. What about catheter ablation? In patients with atrial fibrillation and normal left ventricular ejection fraction, catheter ablation hasn't been shown to reduce total mortality or stroke, as I explained. However, in patients with tachy-induced cardiomyopathy, catheter ablation improve quality of life and reduce total mortality. Here, these are the indications for atrial fibrillation ablation. You have only 2 green boxes here. So if the patient have AF with reduced ejection fraction, so radiofrequency ablation is class 1 indication. Or if other medications didn't work, like antiarrhythmic medications, if they fail, you can give the patients the option of catheter ablation after explaining all possible. They said that exactly patient shared decision. The patient should know everything about the procedure. These are the important key points which I explained about AF catheter ablation. Obesity, obstructive sleep apnea are major overlooked AF risk factors. Usually we don't look at obstructive sleep apnea or obesity for AF patients. They are very important risk factors. Weight loss usually improve outcomes in patients with atrial fibrillation. However, aggressive risk factors reduction, weight management, hyperlipidemia, obstructive sleep apnea, hypertension, diabetes, smoking cessation as very important, plus alcohol intake, even in patients with radiofrequency ablation for atrial fibrillation. Cardioversion is indicated in patients who are hemodynamically unstable. In patients who are hemodynamically stable, we have to go across the chart of oral anticoagulation if there is no rush to do immediate cardioversion. These are the antiarrhythmic drugs for rhythm restoration, including class 1 antiarrhythmic drugs, class 3 antiarrhythmic medications as well. It's important to explain to the patient the side effects of the antiarrhythmic drugs before giving him these medications, because it's important for them to know these side effects. We have amiodarone, we have flecainide, we have propafenone with different indications, and some of them has some contraindications as well. Long-term antiarrhythmic medications, amiodarone is recommended for long-term rhythm control in all AF patients, including heart failure with reduced ejection fraction. Dronedarone is recommended for long-term rhythm control in AF patients with normal or mildly impaired LV function, but the patient should be stable, heart failure with preserved ejection fraction, or ischemic heart disease, and this is class 1 indication. This is the indications of different antiarrhythmic drugs for rhythm control. This is the recommendations for AF screening in cryptogenic stroke. Very important to do ECG, Holter ECG, and longer duration ECG in patients with cryptogenic stroke. So, Chairman Panel, Professor Maqladi, Professor Rabi, and Dr. Damati, this is my take-home message. In these guidelines, there is integrated AF approach, patient-oriented rather than AF-oriented. It's very important to search for stroke, rhythm, or rate control, risk stratification, and there are so many personnel and disciplines which should surround patients with AF: electrophysiologist, cardiologist, neurologist, heart failure team, AF nurse, GP, pharmacist, to give him or her the best support. It's very important to search for the risk factors for atrial fibrillation, and please don't forget the 4S. So we have first to confirm AF, then to characterize patients' severity of stroke, symptoms, severity of atrial fibrillation, structure, severity, then to anticoagulate the patient to control the quality of life and to control comorbidities. Thank you very much.